This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 24, Medication-Facilitated Intubation. Key concepts. After completing this chapter, you will understand differentiating between medication-facilitated and rapid sequence intubation, physiology of neuromuscular blocking agents, including the differentiation between a depolarizing and a non-depolarizing neuromuscular blocking agent, patients who are candidates for paralytic agents, the protective effect of preoxygenation, and knowing the 9 Ps of RSI. Medication-facilitated intubation. Many medications have been validated in the pre-hospital setting, and that's because more and more EMS services are switching to a medication-facilitated intubation now, whether this be rapid sequence intubation or this be the use of sedatives alone. And next topic here is the use of sedatives alone, and this is becoming more and more popular because most of these drugs are a one-drug medication facilitated intubation, whereas paralytic agents require other drugs and they have lots of complication. Every time that we add another drug into the mix, very simply, it adds more complication or potential untoward effects. So paralytic agents, some of them are the most dangerous medications in EMS. Sedation and paralysis. Whenever we talk about sedation and paralysis, the difference between them is sedation is decreasing your level of consciousness, makes the patients more comfortable, less anxious, adds an amnesic effect. As far as paralysis, when we talk about paralysis, we are paralyzing them with the medication. So enables otherwise, the good things about this is it enables otherwise impossible intubations. We wouldn't be able to facilitate an intubation on these people. And it eliminates the needs for face mask ventilation, which makes it a little easier for us to manage somebody that's in respiratory distress. Pre-hospital provider use of paralytics. A long-standing source of controversy, and some are for, some are against. Use does not clearly demonstrate a definitive role in daily EMS practice. There's always going to be special circumstances, but some EMS directors, when they take a look at the overall statistics of this, look at it as, do I want to bring on board a medication that has potential life-threatening complications if we do not facilitate an intubation? So a lot of prep work needs to be done to be sure that the medics are trained, we have the right equipment, and we are implementing the right medication. Now, strong evidence that paralytics can be used safely by selected groups, and there's 2 studies on this. The Wayne and Friedland study showed a 95.5% successful intubation, and on the unrecognized esophageal intubations during the time frame that this study was put on, that number was only 0.3%. Now, this was without the use of capnography like we have nowadays, so, or even colorimetric devices. This was without that, or esophageal detector device, any type of that. So this was just off of, I saw it go through the cords, I heard lung sounds, and I confirmed the tube like that, without any kind of second or third device like we do nowadays. The Ox study focused on head-injured patients with otherwise unmanageable airways, 84% successful intubation rate. Of the remaining patients, all but one were successfully managed with a combi tube, and the last patient was successfully managed with a BVM ventilation. Now, what that kind of shows us is once we've committed ourselves with the use of either sedation or paralytic, we really need to have a backup plan. We have committed ourselves to an airway since we took away the patient's respiratory drive, especially. Medication facilitated in rapid sequence intubation. Potentially has a potential to greatly increase the paramedic's ability to successfully intubate the patient. Effective use requires understanding on how the medications actually work, how they function, and indications and contraindications. Now, the one paralytic, the depolarizing paralytic that we have currently on the market is succinylcholine. Now, it has a ton of contraindications. Not to mean that in the right application it would not be the drug, or that it would be the drug for the actual problem. But understanding how that drug interacts with the body and understanding what that clinical indication is essential in the use of succinylcholine. Pharmacology adjuncts for intubation. Sedatives often used are things like midazolam, etomidate, ketamine, and fentanyl. As far as midazolam and etomidate, both of these kind of work off of GABA. Now, we're not really sure how etomidate works, but for the most part, we think that both of these are GABA agonists. And I realize you all haven't had pharmacology yet, but this will be useful information that you can even look back on. Ketamine is kind of like medical grade LSD, if you will. It causes dissociative, so it'll unplug your cognitive thought from your autonomic nervous system. Wrinkles. So it kind of unplugs both of them. Causes dissociative amnesia, which is a good thing. We generally don't want people remembering that we're snaking a tube down their throat and into their lungs. The GABA agonists have amnesic effects. Fentanyl is mostly for pain, but it does have sedative effects. So combined with our other sedatives, if we're using a paralytic, the sedatives give an amnesic effect, decrease their level of consciousness, and provide very easily going into an easy facilitation of an intubation at that point. Neuromuscular blocking agents. They block the transmission of nerve impulses to skeletal muscles, and there's two types. There's a depolarizing neuromuscular blocker and a non-depolarizing neuromuscular blocker. Now, I'm going to give you the Barney version of this before we take a look at the graphics on the next slide. Adjunctive medicines for this are going to be lidocaine and atropine. Lidocaine, when we utilize lidocaine, it's suggested that this decreases intracranial pressure. Now, there isn't a lot of good studies on that, but it is suggestive that that occurs. So, in a lot of the rapid sequence protocols, if they have head trauma or trismus, we'll actually see the utilization of lidocaine, where either it be a half dose or a whole loading dose, 0.5 or 1 milligram per kilogram. In atropine, heart rates below 80 or below 60, less than 80. All of these would be near bradycardia or bradycardia. If we think that the increased vagal tone, and this is especially in kids, applies, then we should probably apply some atropine as a parasympatholytic because we are going to increase vagal tone. So the depolarizing paralytic, let's talk about these a little bit. The depolarizing paralytic depolarizes this motor end plate so much that it can't respond or create another action potential. Now, this is why fasciculations are caused by the depolarizing neuromuscular blocker, and this would be SUX. But this is how the drug interacts, is it depolarizes the motor end plate so that the body cannot generate an action potential. Non-depolarizing neuromuscular blocking agents. So these essentially block acetylcholine from coming over to the motor end plate. So if it's blocked, this acetylcholine just kind of falls short. Doesn't do anything because it can't generate or start off the action potential. So both of them work similarly on the same part. However, one of them depolarizes and the other one blocks. And this is a picture of the physiology of a neuromuscular junction. If we'll remember back from physiology, motor nerves, this is the actual muscle cell right here. So we get the neurotransmitter or acetylcholine that will kind of bubble up and through exocytosis transfer over to this motor end plate. Now what that does is that tells this side that I need an action potential or contraction to occur, and the contraction occurs. In the normal function, we have acetylcholine that actually hits the receptor site, and then once acetylcholine does its job or transmits its message to activate, the acetylcholinesterase kind of dissolves or breaks down any remaining acetylcholine in this neuromuscular junction. How a depolarizing neuromuscular junction works in a neuromuscular blocking agent is the depolarizing neuromuscular blocking agents. Depolarizing agent creates an overwhelming persistent stimulation to the receptor. Membranes become exhausted and unresponsive to acetylcholine. Muscle contraction cannot reoccur until returned to the resting state. Now, generally speaking, this is the half-life of the actual drug. So if a drug lasts 10 minutes, then for 10 minutes we are going to have a paralyzed state. Now, if we'll notice here, we're not talking about any kind of brain activity or brain blocking anything. We're talking about a nerve and a muscle at the neuromuscular junction. So patients that are receiving this and the next neuromuscular blocking agent as well are all alert. You have to give them a sedative to decrease their level of consciousness and cause an amnesic effect. Now, what that does for us is that stops them from remembering everything that's going on. So, personally, myself, if you had to intubate me, I would not want to remember you snaking a laryngeoscope down the back of my neck. This is a non-depolarizing agent here, non-depolarizing neuromuscular blocking agent. And what these things do is, everyone will pay attention to this right here. Non-depolarizing agent acts to block acetylcholine receptor sites in an overwhelming competitive manner. So they have a greater affinity for that receptor site than the actual acetylcholine does. Neuromuscular blocking agents are shown here in the light red. And what they do is they do not allow the transmission from the nerve to the muscle or the motor end plate. No transmission, no action potential. The 9 P's for medication-facilitated intubation and rapid sequence intubation. Preparation. Be sure all of your items for intubation are within arm's reach. Matter of fact, you should only use your peripheral vision to grab additional tools. Everything should be prepped and around the patient whenever you begin the intubation. If you have to stop and then find an item, that wasn't enough preparation. Predict the degree of difficulty. We can use a Mellon-Potty for this. We can be sure that their patients are a 332. Pre-oxygenate the patient. Very simply, while they're still breathing, turn on a non-rebreathe or a BVM device where it has oxygen in the reservoir, and just have them breathe normally before you even start administering medications. You pre-oxygenate them, you prep the environment, and everything goes a lot smoother. That way, whenever they stop breathing, you can immediately start ventilating. Pre-treat. Any kind of complications that you can foresee, please pre-treat them. If you think the patient is going to become bradycardic, pre-treat that. If you think they're going to have increased intracranial pressure and they are right at the line to herniate their stem, please pre-treat that. Lidocaine versus atropine. Apply cricoid pressure or a burp maneuver, backwards, upward, rightward, and to the posterior. The cricoid pressure at the cricoid ring allows the person that is intubating to see the cords a lot better sometimes. When we paralyze the patient, be sure that our medicine's on set. Please, and pre-treat as well. Let's go back to this one here just a little bit. The pre-treat, please knock down their level of consciousness if you are using a paralytic. I don't know of anybody that would want to be trapped inside their own body, unable to move, and have an ET tube put in their airway. Paralyze, pass the tube, be sure you have good position on it, and you saw the tube go through the cords. Position and secure, and then post-intubation care. The post-intubation care, be sure that all your tapes and stuff and not too tight, or your aftermarket device to hold down the tube, be sure you're adequately ventilating the patient. And be sure they are sedated, and stay sedated during the paralyzation. Continuous, these are equipment lists for medicine-facilitated intubation and rapid sequence intubation. This is table 24.1. Very simply, a lot of these will make sense. Be sure they're on the cardiac monitor in case things start going south. Continuous pulse oximetry, BVM attached to 100% oxygen, an oral airway, a suction setup, end-tidal CO2 detector or continuous EtCO2 detection. Ventilator attached and ready if you're using a ventilator. RSI medications are already drawn up, IV is established, and intubation equipment is present. Conclusion. Medication-facilitated and rapid sequence intubation offer an expanded range of tools. Patients who could not previously be intubated can receive the benefits of translaryngeal endotracheal intubation. Use of these medications is not without side effects, and you can get untoward effects as well. Untoward effects in this type of medication are associated with tons of complications. The actual acts of administering the medication and performing the intubation are no different than in any other patient. The most critical difference is the judgment required to make the initial decision. Do I intubate or not? Chemical paralysis cannot be done lightly or without forethought. Nonetheless, there are clear benefits if the patient requires an intubation. References for this lecture have been from Richard Beebe, Professional Paramedic Volume 1, Foundations of Paramedic Care, First Edition, pages 474 to 489 of Del Mar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.